Good afternoon and welcome to today's Healing the Nation webinar. We're so glad you've joined us this afternoon. My name is Ben Miller. I'm the Chief Strategy Officer for Wellbeing Trust, and it's my great honor to do this presentation today alongside many colleagues that some of you know, many of you, if you don't know, you're going to get to know quite well. This is a special webinar. Today we're going to go deep on California and talk about the future of mental health in California. And as I said, we've got a long list of folks who are going to be able to speak into that. So you all gave us a lot of information that was extremely helpful to understand where we are in California. And I want to walk through just briefly before we get started and get a special message from one of our colleagues, some of the things that you told us about California. Next slide, please. Oh, I should tell you the agenda first. Let's go back to that, Alicia. Thank you. We're going to have an opening from Dr. Tom Insel. He's going to give us a brief remarks. We're going to go into a quick overview of Healing the Nation, which is something that many of you have heard from me before, but we want to reiterate the importance of healing the nation, especially in work in our states. We're going to have a really interesting fireside discussion on how to build an anti-racist system of care, which I think is going to be extremely inspiring and helpful. And then we're going to wrap up with interventions and innovations around mental health policy for the field with just a rock star group of folks. Next slide, please. So because today is about mental health in California and the future of mental health in California, we asked you what you thought about that and how well was California doing. Some of you may remember what you said, others don't, but let me just highlight some high-level issues that I think you flagged. First of all, California has been quite successful generally around increasing awareness for mental health, promoting pilot programs, and looking at some of the major policies that I know we'll discuss today, such as the Mental Health Services Act. Some of you have called out issues specifically around top priorities. On the next slide, please. And surprisingly or not, I think all of us right now, especially those of us with kids, are not surprised by some of these things, because when it comes to top priorities, you all overwhelmingly said youth and school-based interventions, which is great, because today we're going to get to hear a lot about that and some of the solutions for our kids. When it comes to challenges, and we know California is not alone in these respects, you highlighted several, including the need to have strategic alignment and funding oversight. Again, issues that I think that our panelists will be able to discuss in more detail today. And finally, for areas for improvement, we all know the challenges of fragmented work and the need to better integrate across our silos. The size and scale of California makes this difficult for sure, but it's an area that all states could do a better job addressing. So thank you for sending in your thoughts. Thank you for joining us today. These are so important, and we're used to inform a lot of our thinking and planning for today's webinar. So we have a packed agenda. So without further ado, we're going to hear from Dr. Tom Insel, California's mental health czar and an internationally recognized leader in mental health. So we'll start with Dr. Insel.
Thanks, Ben. Delighted to be here with you and others to talk about the future of behavioral health in California. Great topic, and the Wellbeing Trust is the right group to bring all of us together. As you mentioned, I served as the mental health czar for Governor Newsom. I say served in the past tense because I spent last year traveling the state really as his eyes and ears on all issues related to behavioral health. But this year, I've returned to the private sector, and so I'm joining you not with any formal role in this administration, except my connection to the Steinberg Institute, where I serve as chair of the board. The governor likes to say that in culture, politics, economics, and lots of areas, California is always America's coming attraction. I'm not sure that's completely true for behavioral health. In fact, in the study by Mental Health America, the survey found California wasn't at the top, even though we spend more money than most states in behavioral health. We ranked around 26th, I think, 27th, about 34th for youth. So we're not in the vanguard for the 50 states. And to be clear, none of the 50 states would be in the vanguard for the highest quality behavioral health. So we have a long way to go. At the same time, I think that we have a real opportunity here. We've got these extraordinary resources. In the year that I spent traveling the state, one of the things that really stuck with me was how fortunate we are to have just outstanding leadership at the county level and sometimes within cities. We have people who are incredibly competent, hardworking, brilliant at what they do, get very little recognition. We've also got some resources like Prop 63, which brings about $2.4 billion into the behavioral health economy each year. Will probably go down as the tax base reduces, but that is still something that 49 other states don't have access to. And we have great intellectual capital within the universities. We've got an opportunity to work broadly with a range of other partners that are across the state. So I think we have a ways to go, but we have a lot to build on. My sense is that if we want to talk about what I like to call Camelot in California, where recovery is the goal for everybody, where there's no wrong door for care, where our current crisis around homelessness and incarceration and fragmented behavioral health care is resolved by a kind of whole person approach, where we involve schools and families and communities, and we move upstream towards prevention and preemption. If we want to do that, if that's really the shared vision, then we have to get serious about the strategy. So if that's the what, then for me, the how falls into 4 categories. And I'll just quickly lay them out, and I'm sure other members of the panel will go deeper into each of these. But let me just tick them off. First of all, we've got leadership as a key issue, I think, in California. You can't build a winning mental health system for the state 58 ways. You're going to have to figure out a way in this state to return to state leadership. Nobody likes the idea of taking this out of the county coffers, but there has to be a way for the state to set some overall goals for the counties. Where should they be shooting for outcomes? Suicide mortality, incarceration rates for those with behavioral health issues, completion rates in school. Could we set an agenda that says that every young person who has a first episode of psychosis never has a second episode? Those kinds of outcomes need to be laid out very clearly with metrics, milestones, and help for the counties to be able to measure outcomes. We have an opportunity here to create a public-private partnership. This is number 2, where we can overcome the fragmentation of care because we create a single care system for behavioral health. I would say that includes not just the state and the public system, but the private commercial system. It could bring in the universities. It could even bring in the tech industry and the employers who are such a huge part of the insurance market here. Imagine for a moment a sort of single payer for behavioral health in the state of California. I know it's politically radioactive, and yet this may be the time and the place to think about that. Number 3 is workforce. We're going to have to figure out a way to build out a workforce for whatever programs come out of either the CalAIM effort or any other effort that we dream up as a way of getting to Camelot. We don't have the providers we need. We have a lot of providers, but we don't have the providers we need with the diversity, the training, the commitment to metrics, the commitment to outcomes. We need a new cohort of people who are going to be providing behavioral health support in the state. And finally, and I think all the speakers are going to talk about this, we're going to have to move upstream. We can never dig out of this if we're always in crisis mode. It can't be the case that emergency rooms, jails, and crisis stabilization units are the best we can do. We're going to have to figure out how do we engage schools? How do we create what I like to call a future-proofing project based on what's happening in Australia today, where working within the school system, there's an opportunity to really provide the kind of resilience training that you want every young person to have. So I'll conclude by saying that I think that this state, California, can become a beacon for other states in the same way perhaps that New York City through NYC Thrive has become a beacon to 200 cities across the country, which is a really admirable thing to see. We're going to need the political will. We're going to need strategic leadership. We're going to need public engagement. And I'm hopeful that my colleagues on this panel can all be part of a future where we make that happen. Thanks so much for including me. I look forward to hearing all the other panelists, and I know that you're going to get some great ideas out of this extraordinary group.
Well, I hope you all enjoyed the wise words from Tom. Thank you, Dr. Insel, for those words.
Thanks.
I'm now briefly going to walk through Healing the Nation and the reasons that we do these webinars. As many of you know, if you joined us before, we focus on how we as a nation can advance mental health through comprehensive policy. We highlight certain issues that we think are relevant for the day, and we really try and empower each of us to go back to our respective worlds, our organizations, and do something to make a difference. The entire country is learning the power of mental health right now. COVID-19 has really forced us to face a level of uncertainty that most of us have never experienced. There is no better time than the present for us to begin to place mental health at the center of our priorities and really embrace comprehensive solutions that can make a difference for millions of Americans. So as we will discuss today, there are bright spots, places like California, where we can learn lessons that can be applied elsewhere. The last batch of data from the CDC in 2018 showed a modest improvement in treating opioids. I know some of you have seen this slide before, but it's an important one to start for context. There was celebration that we were doing something right, except this was a premature celebration. And in fact, if you dive deep into these data, you can see that while there was a small decrease in opioid deaths, communities of color did not see those same positive gains and actually were dying at increased rates to psychostimulants, things like cocaine and methamphetamines. That's a problem. But yet there was a little bit of a celebration because we seemingly made some difference. We had seen a year where we didn't have a major increase, and that was cause for at least some initial celebration. But that brief pause forced us to reflect on the things that were working, for whom and how well, and were these policies that we were promoting, especially around opioids, truly impacting all communities. I think it was clear that our nation knew we had to do something about a topic that we often didn't discuss, a topic that impacts all of us, whether we're willing or not to admit it, now or then. That's part of the reason why we're out here today. This is our attempt to bring us together, to create a call to action, to align strategy, a strategy to save lives. Because for the last 20 years, and possibly longer if we had the data, the trends show nothing but the data going in the wrong direction for mental health and addiction, especially around mortality. And as a reminder, those deaths that I just showed you were all before COVID, before a time when we were more isolated, before a time when we lost our jobs. Now it's hard to say how much worse it could be, but I think it's safe to say that it will be worse. And preliminary data support this, though this is still pre-COVID. Until a few weeks ago when we got these data, the CDC came out with the preliminary data from 2019 that showed nearly 72,000 Americans died from drug overdose deaths. And if you look at that, that's an increase in 5% from 2018. And it's scary for me, especially when you consider the context of it. This is actually higher, the deaths to drug overdose are higher than the peak yearly death totals ever recorded for car accidents, guns, or AIDS. And so we have to embrace solutions that are going to do something about this. So we're simply not improving fast enough, and more lives keep getting lost. So many of us on this call today, on this webinar, we've made that call to action. We've made the call that our nation has not done enough to stem the tides of deaths of despair. We didn't before COVID, and we're not during COVID, which means that someone needs to talk about how bad this can get. And we did this on a previous webinar, and I'm highlighting it again today because we projected how many additional deaths of despair might we see from COVID-19. And there obviously exponentially could increase over the next 10 years if we do not begin to address the epidemic within the pandemic, the language that we used then, the language that we use now. Because we have got to get behind solutions that are thoughtful in ways that we can more significantly address mental health and addiction in our communities now. So yes, this is a wake-up call, one that many of you have also heard, and it's not a time for timidity or workarounds. That's part of the reason why we wanted to do today's webinar. Another solution that we brought forward to you, which I want to highlight, is that Wellbeing Trust in collaboration with Kaiser Family Foundation has released a series of state fact sheets highlighting key data about mental health and substance use needs, as well as capacity within our states. Just to give you a couple of examples of the data points that are in here, because they're extremely relevant for much of the work that we're doing. And my friends at KFF did tell me that California is often the most clicked upon state. So there's some connection and tie in there. Mental health issues have increased significantly during COVID. And actually, if you look at the number of individuals reporting symptoms of depression and anxiety, it's around 36%. If you compare that to last year at the same time, it was only 11%. So, I mean, I think that says a lot about how mental health is impacting us all through COVID. I'll give you one other stat here. Deaths due to drug overdose increased nearly fourfold nationally, as I've already described, from 1999 to 2018. What these fact sheets will give you is that you can actually look specifically at the states and see how one state may fare over another. For example, West Virginia and Delaware have the highest age-adjusted overdose death rates, more than 5 times the rate in South Dakota and Nebraska, which have the lowest rates. So, and at the heart of many of our problems and so many of our solutions is policy. In a recently published article that was just wonderful in Milbank Quarterly entitled U.S. State Policies, Politics, and Life Expectancy, the authors described how changes in U.S. state policy since the 1970s, particularly after 2010, which was when the ACA happened, have played an important role in the stagnation and recent decline in U.S. life expectancy. But policy works in both directions. It can improve health too. For example, some specific states' policies, which I know many of you have advocated for, like tobacco, labor, immigration, civil rights, and environment, can lead to more positive health in our communities. And this is why we launched Healing the Nation, to create a federal policy guide that can offer a way forward for mental health in this country. Together, we must remind Congress that mental health is not an afterthought. It's not something that should be relegated to the sidelines, but it's actually essential for our health. And we know that when healthy community conditions are aligned with things like good health insurance coverage that's affordable and inclusive policies that take into account community conditions, we actually all get better. The overall health and well-being of our nation can be achieved. But as we outline in Healing the Nation, accomplishing this goal requires a framework that sees mental health as existing on a continuum. And that framework is something that we'll come back to a couple of times today, but it's actually the grounding element that makes this work unique. So we may see one important area on the next slide, like criminal justice, which is in need of a major reform. Reform which wonderful organizations like Coaches or Community-Oriented Correctional Health Services are working at the intersection of Medicaid, policy, mental health, and public health. They're pursuing this. But if all we did was just look at criminal justice without taking into account how it connects to our education system and how it connects to our healthcare delivery system, how it connects to our coverage, we're missing an opportunity to be much more comprehensive in our response. The key point to this framework is that solutions in healthcare that are built on the back of a program are not sufficient. We must address the underlying community conditions and then connect the dots between programs so that we have more of an integrated approach to health. We must look at how we can create integration at multiple points in our communities and in our clinical settings. You can get more information at the website, which some of you may have memorized by now, healingthenation.wellbeingtrust.org, where you can download individual policy briefs that you can immediately use, or you can just find out more information around the topic at hand and what we're discussing today. So we're working towards updating our first version of Healing the Nation into a second version that'll be coming out probably early next year. And we've also got a people's guide that we're going to be launching probably in the fall of this year that is a guide that's really aimed to give to community members so that they can take their ideas, especially around policy, and move them to action. I want to wrap up briefly by talking a little bit about the importance of the social movement here, the social movement principles. Having a framework and policy actions can only take you so far. That's why we must apply a social movement principles to help us advance the mental health movement. So on this slide, you can see the 7 core elements that have been present in other movements. Thanks to our friends at Civitas for teaching us these, as their successes have really shown us that we can have wins in critical areas like marriage equality. They can be inspirations and guideposts for us all. So building off this important infrastructure needed for social movement, I want to highlight 2 aspects of the movement building that Wellbeing Trust is supporting. Both of these efforts are aligned with the Healing the Nation framework and are working to change how our nation addresses mental health. The first is around policy. You need robust policy muscle to support a movement, and that's where Inseparable comes in. Inseparable aims to revolutionize mental health advocacy by empowering people to stand up for one another, by demanding access to care for those individuals who are suffering but often illegally denied coverage. And Inseparable is focusing on multiple areas. Bill Smith, the founding director of Inseparable, he's going to be leading a panel here in just a few minutes, and you'll get to hear more from him. So you got to have the policy muscle. You've also got to have the financial engine. Mindful philanthropy represents a part of the movement that is able to really help establish a financial engine for advancing mental health. This new nonprofit's goal is to increase high-impact philanthropy by connecting grant makers and donors to knowledge funding opportunities and networks. You can learn more about mindful philanthropy by going to the website at mindfulphilanthropy.org. And I should have said for Inseparable, it's inseparable.us. So in closing, it's clear that we need to move to action soon. And orgs like Inseparable and Mindful Philanthropy can help. But it's also a place each of you can help. We need each other, perhaps now more than ever, to bring forward a change around mental health. I want to offer a stark reminder that our nation is hurting, it's in pain, and we're hurting due to longstanding issues of race, which we'll talk about today, inequity. We're hurting due to the impact of bad policy, hurting because of social isolation and loneliness, and just frankly, uncertainty and fear that comes from something like COVID. That healing can begin with each of us turning to each other, but also each of us turning to our Congress and our local officials and asking for more robust change. We need to pursue innovations that are led by community and embrace the challenge of changing structures that have long perpetuated the disconnect between the mind and the body. And we need to do so in a way that is grounded in a framework for excellence. So thank you all for joining us today and for what each of you are doing to advance mental health. I'm now going to turn it over to Tyler for his Fireside Chat with Alex Briscoe and Rhea Boyd from the California Children's Trust.
Greetings. My name is Tyler Norris, and I'm the CEO of Wellbeing Trust. We're an impact philanthropy whose mission is to advance the mental, social, and spiritual health of the country. I'm really looking forward to this dialogue with Dr. Rhea Boyd, the Director of Strategy and Equity at the California Children's Trust, and its principal, Alex Briscoe, to discuss with us what's possible here in the state of California. And before we invite these two thought leaders and advocates into the conversation, just a bit of background. Wellbeing Trust was born 3.5 years ago in early 2017 at the combination of Providence and St. Joseph Health. This large faith-based, mission-driven health system from Anchorage to LA, including bits of West Texas and Western Montana, believes that healthcare is a human right and that mental health is essential as part of healthcare. There is no health without mental health. And as part of its combination, it made a commitment to prioritizing, addressing mental health challenges, addiction challenges, and to reduce and eliminate deaths of despair. Not just the deaths of despair that have been articulated by the work of Deaton and others for white people, but all of those who are impacted by anxiety, by depression, by suicidal ideation, by struggling with addiction, and those whose lives have been traumatized by early childhood, by toxic stress in communities, and other community conditions that are not supporting human flourishing in the first place. Back in the day when our Senator Kamala Harris served in a different role here in California, she asked the new Providence St. Joseph Health, now Providence Health, to invest $30 million in improving the mental health for Californians. That gave Wellbeing Trust the opportunity to invest here in California in place-based initiatives that can create the conditions for well-being, in clinical community partnerships that would expand access to integrated whole person care, and that would help move this state towards having the kind of infrastructure that will allow us to create systems of care that work for all people in California, that preference those who are poor, vulnerable, and who have been left out of access to actually disproportionately invest, as we know we must do with health equity. That $30 million of resources has been deployed, and we were very fortunate to be able to invest a slice of those dollars in California Children's Trust in its vital mission here in California, and certainly as a model for the United States of America. So with that, I'm really we're so thrilled to have Rhea and Alex here with us. And Rhea, if I might turn to you first, because what a time in our country, and I'll let you try and characterize it rather than me really beginning. But you have written so beautifully about children's health and racial disparities in the health field. As we think about redesigning systems of care, expanding access, the voice of lived experience, the voice of young people, the voice of Californians is so important. And you have your finger on the pulse of that right now. How should we be listening to young people and their needs and aspirations right now? What should we be doing as policymakers and in listening to them? So please, Dr. Boyd.
First, thank you so much for having me. I'm so excited to be here alongside my good friend and colleague, Alex, too. What a time I think is right. This is a very disorienting and in some ways devastating time for our country. I think we are all witnessing the impacts of racism on our society broadly that perhaps were hidden from certain communities in our society because of how complete racial segregation is in our communities. So, for example, the police violence that Black and Indigenous and immigrant and Latinx communities have been decrying for decades, if not centuries, has now been placed on many people's radars. And as we watch that in the middle of a global pandemic that our country is failing to address, I think it has been a really distressing time for kids, families, and honestly, anybody who's paying any attention. And I like what you say. I think it's really important that we right now pay attention to how our kids and youth are doing. Because although adults may be suffering the burdens of job loss and job insecurity and housing insecurity as a result of this pandemic, and all of the economic toll it's taken on communities and families, I think kids absolutely feel the stress and strain as well. Primarily because many of the sites kids go to cope and play and have supportive relationships that support their social emotional development, those sites are changed or completely closed to them. Here I'm referring to school closures, camp closures, closures of public spaces in general, closures of parks, of play structures. Kids at all ages just don't have access to the things that help them thrive right now. And they're relying on adults and parents who are increasingly stressed as well. So I think listening to our kids about what they're experiencing, going through, and watching how they're internalizing and responding to this moment is really critical. So even for kids who perhaps can't articulate what they're going through, maybe because of their developmental age or because of the acute stress it's taking on them, and perhaps they lack the language to describe it, I think parents can also start to pay attention to their behaviors, increasing isolation among kids, increasing erratic behaviors or aggression in kids can all be signs that they're having trouble coping with the moment. And it might be the right window for parents to reach out and say, hey, this is a hard time for me too. Can we talk about how you're doing?
As a pediatrician, this is so helpful to be hearing you think about behavior, because young people can't always find the words, or we don't always hear them in the way that we might. Lack of access to food for so many young people, lack of access to mental health, their coaches, the teachers that love them, wildly disorienting, and sort of the sense of what can I count on? Maybe a bit invisible for us, but children are feeling this deeply. As you hear young people, and now we find ourselves moving towards readiness for school, how should we be thinking about reopening? How should we be thinking about reopening altogether, but particularly reopening safely? And what are the relative benefits and risks? And not only what should we as California be doing, but as parents and caregivers, how should we be thinking about school opening and supporting our children? Not to mention the teachers and schools that they're going to.
Yeah, absolutely. This is a huge question that's on everyone's mind right now. How do we place kids in environments where they can thrive? And schools have traditionally been that environment. But in the setting of this pandemic, and honestly, our failed government response, we have not done the things we need to do to make the community spread of COVID low enough that schools can do something to make schools safer than the rest of the community. So I think schools are really in a bind right now, and parents and teachers and staff are in that bind with kids. There's two sides, I think, of it. One, I think it's really critical to recognize that decades of work has placed critical advocacy supports for kids within schools. You highlighted some of those, like nutrition. You know, schools feed, the government funded school nutrition programs feed like 35 million kids a day. And it's been estimated that meals that kids receive through schools make up 2/3 of their daily nutritional needs. Like, schools are feeding our nation's kids. It's also where kids get healthcare. Our nation has more than 2,000, school-based health clinics where kids get their primary care, their behavioral health care, their mental health care. Schools are also places where teachers and staff are what we call mandated reporters, which means they're places where there's another set of eyes on kids to acknowledge if kids are in acute distress or if they have signs of neglect or abuse in their home. So there's been a lot of concern that as families all have to shelter in place, and perhaps for families who already have a history of violence in the home, that kids aren't being seen in other environments where they might be able to have sanctuary from that form of violence. So we have a lot of concerns about kids not being in schools because we work so hard to put so much in schools for kids to benefit from. At the same time, we're in the middle of a pandemic, and to make it safe to go to school, we would have to decrease the local spread of COVID. And here in California, unfortunately, we are one of the top 3 states with the highest number of COVID cases and a growing, alarming number of COVID deaths. And recent data told us that kids aged 10 to 19 can transmit COVID within their homes just as effectively as adults, if not more. So the concern with reopening schools without a safety plan at the community level is that it will lead to COVID outbreaks among kids and their families. And I think that concern is really legitimate. So what I've been calling for, and I'll kind of pass it off to Alex here, what I've been calling for is a robust growth and strengthening of our safety net. If we place all those supports in schools, we need to now find another way to provide those supports to kids if it's not safe to open their schools. We need to look at home-based supports and the payment models that can support kids receiving their special for kids who have special needs, receiving their special education supports within their home, for kids who parents elect to homeschool them as a result so that they can receive adequate supports for learning in their home, food supports that can be delivered to people's homes, paid parental leave so parents can stay home if their kids need to stay out of school. Like, we need to support families. And I think it'll take the government saying that we will provide income supports to every family to do what it takes to make it safe for their kids to continue to learn in these alternative ways that we're forced to consider now, given the pandemic.
Right, Dr. Boyd, that's so helpful, because I think so many of us find ourselves in this kind of binary polarity: open schools at all costs or don't until we're ready. And I think you're putting an interest on the table of what we can do to make sure that we're meeting the needs of kids as we discern the right timing. And that I really appreciate that. Alex, if I might turn to you for a moment, tell us a little bit more about the California Children's Trust, and specifically, what are you seeking to accomplish? It's an extraordinary opportunity for you here in California. You've gathered an extraordinary team and momentum behind you. Tell us a little bit more about what is your sort of core policy recommendations you'd like us to understand.
Thanks, Tyler. At the heart of our work is a belief that we have to reinvent our approach to supporting the social and emotional development of children. And at the heart of all of that work is an acknowledgement of the impact of structural racism and the stabilization of poverty on young people. So before I answer your question directly about our specific policy recommendations, and I'll make 3 very specific ones, I think we need to put in context COVID and the current crisis and a crisis that preceded it. In the decade before COVID, twice as many children were admitted to hospitals for self-injury. There was a 104% increase in inpatient admissions for self-injury. While lengths of stay, meaning the numbers of days you spend in the hospital, had decreased across all disease burdens, they were up 50% for pediatric mental health. And our public mental health system was deeply troubled. Less than 5% of all children got access to anything at all in the Medicaid program in California. So while we talk about this extraordinary circumstance that Ria so beautifully named, it has to be put in the context of a precursor that was a legitimate public health crisis in the lives of children. Young people were telling us that something was going on, and it wasn't because they were all pathological. They were telling us that the experience of being a child in this culture was life-threatening. During that decade, suicide leapfrogged cancer and car accidents as a cause of death. So we use the term despair, I think, maybe too liberally, but I think it's accurate to say that low-income children were in the throes of an epidemiological crisis of despair. And to your very good question to start, they were telling us, the California Healthy Kids Survey in California surveys children every other year in every classroom in California. And children were telling us that they were experiencing a 67% increase in self-reported mental health needs. So young people were telling us, the hospitals were telling us, and it wasn't because kids all of a sudden got mentally ill. It was because our culture was making them sick. And so to answer your question directly, the first and foremost specific policy recommendation we have is to remove diagnosis as a prerequisite for access to care. We think that this is the greatest symbol of structural racism in the children's mental health system, that a largely white professional class pathologizes a largely brown and black beneficiaries to justify their paycheck. And I have personally billed hundreds of millions of dollars of Medicaid mental health services in schools and FQHCs and emergency departments and juvenile justice settings and foster care settings and home visiting programs. The vast majority of the children that I personally have served were not pathological. They were dealing with the challenges of living in a culture that told them they weren't worth nothing and not having adult allies to support and encourage their beauty and wisdom. So this critical and essential policy recommendation is not just a social justice action. It's not just a response to structural racism. We actually believe it's consistent with the federal EPSDT entitlement that specifies that children have a unique status under the Medicaid program. And that status means that they get everything they need to grow and thrive. And so as a very simplistic comparison, you don't have to have measles to get a vaccination. That is the same benefit that covers mental health. But in California, you must meet one of 17 diagnostic criteria to get access to care. So the first and most important policy recommendation, maybe not the most important, but the essential one to help understand our broader frame, is to remove diagnosis as a prerequisite for care and reinvent mental health as a support for healthy development, acknowledging the impact of structural racism, not as a response to pathology that blames children for reacting very rationally to a culture that has denied them opportunity. The second policy recommendation I will make is we think that there is a massive opportunity to generate a multi-billion-dollar investment in the social and emotional health of children by claiming against expenditures the state of California is already making. So to understand this concept, you have to have a very rudimentary understanding of Medicaid. So to distill the whole program really quickly in 30 seconds or less, one way to think of Medicaid is like a pot of gold sitting in DC. You get $1 if you put up $1. So every Medicaid expenditure is part state, part federal. California taxes itself among the highest levels of states in the nation, but it spends the 40th most. So if your mathematical mind is going at all, you're thinking, wait a second, we tax ourselves at this level, but we get this much match. So the way we try to describe California's Medicaid program is like a shriveled Charlie Brown Christmas tree with a bunch of pretty Christmas tree ornaments hanging on it. Mm-hmm. There are lots of local and state revenue programs from this kind of serial entrepreneurialism of the California safety net. Great things, Prop 63, Prop 64, Prop 10, which have generated lots of revenue, but haven't been used to pull down a federal match. And then the final policy recommendation we have is to center schools as healing and anti-racist centers of pro-social support. The medical model not only is constrained in its diagnosis-driven identified patient model, but young people use primary care at the lowest level. Children 8 to 18 have So if you wait on children to go to a primary care doctor and get a referral for mental health, you'll have waited far too late. Schools are essential actors in any response at scale to the challenges facing children. And they also have the essential ingredient to Medicaid, which is a lot of eligible dollars that aren't being matched. So those are the three big ones. Tyler, I'll stop there.
That's really helpful. So those are three very specific thuld that we could actually act on right now to remove that barrier around diagnosis, to claim those expenditures, and to center schools in that way. If you could just name it in just a second, and then I'll come back to Dr. Boyd. If you could just name it, what is in the way of us doing that?
Oh my goodness.
Why are we here when that's so relatively clear? Yeah.
First, I would say I think everyone's doing the best they can with the information available to them. So this is not to place blame or, but to answer your question directly, skill, will, and culture. So we have built a medical model on the back of a professional class that does not reflect the lived experience of its beneficiaries. 80% of the almost 6 million children in California on Medicaid. So remember, 6 out of 10 kids in California are on Medicaid and growing, are Black and brown. So we must fundamentally address this power differential between the professional class and the beneficiary class. A policy recommendation I stated that I did not state, which I should have, is that to build an anti-racist mental health system, you must change who does the work. Mm-hmm. Not only who's eligible, so remove diagnosis, but we must expand the provider class to use extenders and others with lived experience who reflect the experience of marginalized communities, or we will replicate the power dynamic in perpetuity.
That's really, really helpful. Dr. Boyd, I'm thinking a bit about those three elements that Alex just laid out. Where have you seen that work, or what do you think that could actually mean in terms of example on the ground that you might give us a sense of what that would actually do for our young people?
I love what Alex is saying there about who gets to benefit from all of the collective resources we as a society place in public programs like Medicaid and in their mental health support specifically. I think I would alter it a bit to say we should change who is compensated for doing the work. Because I think, right, most kids, if only 5%, as Alex has said, of kids who have Medicaid are getting a benefit, they're having their needs met somewhere, somehow. And those folks who are meeting those needs in the relationships they have in their life with their peers and their teachers and their parents and their neighbors, those folks are not reflected in the mental health workforce. They're not included in the economic development that goes into maintaining that workforce. And obviously they're also excluded from the professional opportunities to grow in that workforce. So when we say that we want folks to be compensated for the work that they're doing, it's one way to recognize both people's lived experience, but also the work they're already doing to buffer the effects of inequality on kids' mental and behavioral health. I think it's also to say that when we exclude folks from that workforce, we contribute to the sources of inequality that drive these behavioral health needs. So if we're talking about who does that well, I think great examples that have also worked with us in the Children's Trust are Young Women's Freedom Center and RISE in Richmond. Young Women's Freedom Center is based in SF. They also have an office in Oakland. They are also opening an office in LA. You know, they have models of what I guess would fit under the umbrella of youth development, but is so much more. I think the assumption for both of these organizations is not that youth don't have what it takes to survive. It's like the opposite, that somehow youth are surviving and thriving. And that as a program, they don't have to place constraints around what that looks like. Kids don't have to jump through hoops the way our medical model makes them jump through hoops to be pathologized. They show up, they already are somebody who's thriving, and then they just give them opportunities to continue to advocate for their broader, for the needs of their same kind of social and age group in the cities that they live in. So I think if people want to look more into RISE in Richmond and Young Women's Freedom Center, I think they're models where they have engaged and compensated as their primary workforce youth.
I'm fascinated by what you're both describing, and Ria, in this, there's really a multi-solver in what you're describing. Because in a way, as we look at an integrated delivery system that is more nested in the community as a source of development broadly, you're talking about really reinventing what the workforce actually looks like and who is compensated for that, which means jobs, it means money in the economy, and it means culturally sensitive, appropriate, because it's sort of by and for the community. That the mental health system of the future is very different than what we're thinking about in the specialized, isolated elements that's addressing. I'm so struck by, I guess, I don't know a better way to say it than the multi-solver community building quality of what you two are describing. It feels transformative, not only in just the mental health perspective, but it feels that for communities, and it has to make me thinking of, as we think about what does new policing look like for the future, that this model has very much to say about that too, that it could very much inform where do we go and who's responding to much of what happens on our streets, rather than tactically trained police officers in each instance.
Absolutely. I'm so glad you brought up policing, because I think these are absolutely models of mutual aid, where communities help communities, where when you need help, who you call is your neighbor, somebody that you trust. Who you call is your cousin, your family member, your best friend. That's what youth are already doing. It's what families are already doing, and it works for them. The problem is that we've completely delegitimized that type of aid, and then we've excluded those type of workers from our workforce. These are ways that our healthcare workforce supports and reinforces economic inequality along racial lines in our communities. And it's something that we have to own. I think it's one thing to say, we have a predominantly white workforce. It's another to say the result of that predominantly white workforce is broader racial inequality, economically, socially, politically, in communities. And if the roots of the behavioral health problems that we're talking about, if the roots of despair is languishing in inequality, and you're in access to support so that, you have the prospect of mobility in your lifetime, which young people don't have in the same way that generations had, half a century ago. Like, if that's what the root is, then we have to own our role in perpetuating that. And that's why we're bringing folks on, not just because
I'm so grateful to hear you say this. I have a therapeutic appointment with my psychologist later today, out of pocket, of course. And I'm realizing that in the very system that I am part of, it is absolutely contributing to what you're describing. And I'm grateful for this. It just was a reminder of the work that white people need to be doing. Alex, in our last couple minutes, we'd love to have both of you be able to share just a bit about, oh my, this is such a leadership question, of what needs to be done, thinking about what might our governor be doing, what might all of us be doing to help our governor and his team move this forward. Essentially, what is the call to leadership here in our last couple minutes, the kind of things we all need to be doing ourselves in our organizations and supporting our state?
Yeah. Well, first and foremost is to honor the conversation we just had, which is that people aren't the problem, they're the solution. So there's a essential cultural flip and frame that has to be done, because all the things I'll say next can't be done without that. Like, if you don't actually see the beauty and wisdom of people and the ability of low-income communities to survive despite, then you can't do this. Like, that has to be first. But then there are a bunch of real specific stuff you can do to change the needle. You can change the definition of medical necessity in the current state plan. That's the mechanism through which you remove diagnosis as a barrier to entry. You can fully fund the EPSDT entitlement, as I mentioned, by claiming against existing expenditures. And you can decentralize the mental health workforce and adopt the model that we just discussed. It has various different names, peer-to-peer, social models. By the way, it's not new. Rhea used the term mutual aid, but it actually happens in privileged communities all the time. Wealthy people who have cancer jump on their website and join a support group and learn about which drugs work and which drugs don't. The 12-step community has for over 40 years joined together through a common experience of suffering with no clinical intermediary and helped each other. We have to actually bring those same models of mutual support and care formally and officially, and yes, with reimbursement for time. So a decentralization of the mental health workforce that honors the lived experience and adopts social models, those are all things that can be directly written into the way that managed care organizations and mental health plans structure their reimbursement.
Well, that is incredibly clear and certainly gives us a clear direction forward. Dr. Boyd, might we give you the last word, kind of thinking about our kids, centering our kids in our schools, in your call to leadership now?
I guess the last thing I'll say is many of the things Alex outlines we could do with little to no funding. But I also don't want to pretend that we don't need an enormous investment from the federal government to states like ours in California to make things like this more possible. I think I am a huge proponent at this point of universal health care and universal basic income, at least during this pandemic. Everybody needs more supports so that people can do the things that keep them and their families safe, and so that people have choices to stay safe. So I would implore, Governor Newsom and his administration to think critically about calling on the federal government for a real federal relief package that'll help families get through this time and transition into the future that the California Children's Trust and Alex and folks are envisioning.
Dr. Rhea Boyd, Alex Briscoe from California Children's Trust, thank you for your guidance today. We deeply appreciate your partnership. California can and must do better, and we may all be having a very different experience, but we're in this together. And I think you're reminding us what all of us can be part of to help transform the health and well-being and make sure that every kid has a shot at realizing their full potential. Thank you both.
Thanks, Tyler.
Thanks so much.
Greetings.
So if you all weren't fired up before, you probably are now. And if you didn't think that you liked Medicaid before, you probably do now, because if anybody can make Medicaid seem appealing and easy to understand, it's people like Alex and Rhea. So thankful for their conversation with Tyler and for some of the amazing insights that they brought to this issue. If you haven't been following along, there's a couple places I want to draw your attention to before we start our next panel. One is just the webinar chat. A lot of you on here are tremendous experts that have been weighing in, and thank you for that. There's some resources that have been put down, links, lots of ideas. I wish we were all in person in a room so that we could have this discussion together, but you'll see some of the common threads that are emerging. Two, down below, there's a Q&A button. We are going to reserve time at the end of the next panel to have some Q&A with this panel. So we will be able to go a little bit more into your questions and get some answers. So when you hear our next panelist, if you want to go ahead and type some more questions in, we will try and get to them at the end of today's webinar. So without further ado, it is my distinct honor to turn it over to my good friend and colleague, Bill Smith. Bill is the founding director of Inseparable and which I've already discussed once today. Bill will probably get to talk a little bit about Inseparable, but he's going to introduce our next panel. So Bill, over to you.
Thanks, Ben. Appreciate your leadership and for Wellbeing Trust for bringing everybody together today. And wow, Alex and Dr. Boyd and Tyler, thank you for that conversation. In the chat, Jeffrey Ring called it beautiful clarity. And I thought that was exactly right. It was a powerful conversation about the future that we can create. We started Inseparable with a pretty simple premise. You can't separate the health of our minds from the health of our bodies. And yet we live in a system that often does just that. Our mission is very straightforward. We want to bring people together to build the political power to do the work that Dr. Boyd, Alex, and Ben have been talking about today. And while we're about to dig in to learn from these incredible panelists about what's working in California, I would be remiss if I didn't call our attention to the debate that's happening in Washington right now. Dr. Boyd nailed it. We have to advocate for federal funding. In the first round of stimulus in May, mental health was barely a part of the discussion, even when we know that the mental health crisis is exploding in our country. So before we go to the next thing, I would just ask you to please take a moment today to take the time to call your member of Congress if you haven't done so already, and ask them to fund mental health. If you need help finding that person, there's a link that just went into the chat, inseparable.us/fund mental health. We need to make our voices heard. And with that, I want to turn to our panelists and hear about some of the promising things they're seeing so that we can move from that distressing and disorienting moment that Dr. Boyd so beautifully described that we're in, the long-term crisis that Alex discussed that preceded it, and to move closer to the Camelot that Dr. Insel mentioned at the beginning of our time together. So we're going to hear from our panelists briefly, and then we're going to have time for Q&A. First, we'll hear from LaShawn Francis, the Associate Director of Health Collaborations at Children Now. Then Dr. Virgil Morehead, the Executive Director of Two Feathers Native American Family Services. Then Dr. John Goldfinger, the CEO of Dee Dee Hirsch Mental Health Services. And finally, Maggie Merritt from the Steinberg Institute. So with that, I'll turn it over to LaShawn, who I have to also brag is a member of the Inseparable Advisory Board. LaShawn?
Thanks so much, Bill. Good afternoon, everyone. I'm really excited to be here and to, follow up after that conversation with Alex and Dr. Boyd. I'm not sure that what I have to say is going to necessarily be inspiring, but I hope it'll be informative. And today I really just want to take some time to focus on where we as an organization think Children Now think California is when it comes to children's behavioral health and where we think the state should be. Next slide, Bill. I'm not sure who's monitoring or who's doing the slides. Thank you. This is actually national data, and it's an opportunity for me. You all can read, so I won't go through the actual statistics, but it's actually an opportunity for me to highlight my complaint about the availability of state level data. And there is a saying in public health that what gets measured gets funded. So part of our underlying push in a lot of our work is for the state to do a better job understanding where kids are and comparing it to where we want them to be. As a shout out, the Trevor Noah Project actually just did a national survey on LGBTQ+ youth and their mental health, and I've included some of the statistics there. But what's not here on this slide is some of the concerns that we know young people have due to things like housing instability, personal debt. We know that while all youth stress about things like mass shootings and climate change, youth of color are disproportionately more stressed about housing stability, to the tune of about 41% are concerned about housing instability compared to their white peers who are concerned at about 30%. Personal debt, we're seeing the same gap. About a quarter of youth of color are concerned about personal debt, and about 34% of youth of color are reporting hunger and not being able to get enough to eat. So, I really could have filled this slide up with a lot more statistics to answer the question on the state of children, but we, have time limits on this. So what does this all mean? Next slide. So usually, when I start a lot of my presentations, we kind of get into the nitty-gritty of, who the stat is about and what the stat is saying. But I really, really enjoyed this quote. When a flower doesn't bloom, you fix the environment in which it grows, not the flower. And our temptation has always been to try and fix the individual without close examination to the circumstances of our children. And I really want us to begin to focus, as we call it, upstream, but really what we're talking about is providing the needed environment for children and youth. Next slide. So this is a framework for children's mental health. And, like all frameworks and charts and diagrams, they are, very hard to try to distill into just a few pictures and images. But I think it's a good starting point to the question of what is needed to have emotional wellness for children. And you'll notice that we start in the prenatal stage, and we know that's important, right? We know that the creation of a healthy brain architecture in the first 3 years of life is dependent on good health, positive and nurturing relationships with adults, exposure to enriching learning opportunities, and safe neighborhoods. So when these environmental and biological components aren't present or positive, behavioral health concerns may become more apparent during one's childhood and adolescence. And I know that many of you are already familiar with some of these concepts. So I'll just highlight the bottom where they talk about, who this framework is for. And this slide defines universal versus targeted versus clinical, right? And those are approaches in terms of our policy. Are we taking a universal approach, a targeted approach, or our clinical approach? And I think for California, you'll find that we have spent a lot of time on our targeted approaches and our clinical approaches. But we haven't done a lot for our universal approach, which is where we would begin to question things like, what is happening in the family? What is happening in the neighborhood? What's happening at schools and communities, with the state and the culture? What are those protective factors and those risk factors that we need to invest in? Next slide. So at Children Now, we see this juxtaposition between what's currently happening and what needs to happen, right? So we think that largely California's efforts have been piecemeal, and they've fallen short for kids. Many of the efforts, like I mentioned, have been targeted and clinical in regards to population, but we haven't really taken a more comprehensive approach. And we know that this is important because with kids, we have the ability to really intervene early and not be so reactive to the state, right? Or to the state of children, but really to be proactive to the state of children. And so that's what we really want. We want to see the ability for the state to not shift away, but to incorporate a universal approach so we can have the opportunity for interventions. And currently we are focused heavily in our healthcare system. And, I think my colleagues before me spoke about this a little bit, but if you look deeply, most of our legislation and policies on mental health care are heavily focused on payment reform, hospital beds, health insurance coverage, and these things are important, right? I'm not saying that they aren't important, but they aren't the full story when it comes to children, right? And we have such a unique opportunity on the lives of young people to be preventative that we really need to think about how we invest in communities, not just how we invest in systems. And I could talk a little bit more later about what we mean when we talk about investing in communities. And I think, for us, one thing that we have been seeing is that the state is simultaneously involved and invested in harmful policies or practices to youth. And there needs to be a change with that. We need to actively disinvest from those policies and practices that harm youth. So what do I mean by that? So California spent the last few years really revamping their school suspension policies when it comes to willful defiance, right? And really quickly, just to kind of let you know, this has been a long-standing effort by many advocates who are fighting against the school to prison pipeline and really drawing the link between behavior, the definition of behavior, and a child's emotional wellness, right? And so we have tackled that in a very big way in the state of California. But one thing that we haven't really done is taken a closer look about suspensions related to drug-related suspensions in California. And so in our 2017-18 school year, over 60% of drug-related suspensions involved Black or Latinx youth. And this is important because many students may not get the support or counseling they need, as the instinct for schools has been to punish and not to help. And so I have several examples about what it means to really disinvest from those policies and practices that harm youth. But I noticed that I'm running out of time, so I'll try to wrap it up. You know, we really know that mental health is broader for most people, and we're interested in making sure that a child's social and emotional well-being is thriving by investing in their environment, reducing opportunities for traumatic events, and providing high quality supports and services that will allow all children to reach certain developmental and emotional milestones. So I'll stop there, and I'm sure that I'll be able to have a robust discussion with some of my other colleagues on the panel and pass it on to Virgil.
So hello, I'm Dr. Virgil Morehead, Jr. I'm the Executive Director here at Two Feathers Native American Family Services. And, you know, the theme of this panel is very relevant to me. From the first day I chose to pursue a career in mental health, I've asked myself, what does a mental health system look like that better serves Native American people? For me, the answer to this question is we have to start by recognizing that for far too long, the history of Native American people in this country has been told to us. Native American, experiences were written down, researched by those who do not know our culture, our traditions, our ways of being. And so to start, we must start with acknowledging that the mental health system, including in California, is not an exception. It's not an outlier to this paternalistic attitude towards tribal nations. Please change slide. We must also recognize that although small in numbers, Native American people in California are diverse, complex communities who most importantly have solutions to many of the community and mental health issues that plague their communities. I come from the Big Lagoon Rancheria. I'm part Yurok and Talawa, and currently, like I said, the Executive Director at Two Feathers Native American Family Services. And I think, at Two Feathers, we recognize that we have solutions, but we also don't have the answers. We do need assistance. So I think this is a timely panel during this time. Next slide. And so if you think about the Native American mental health, I think an important question is, where is Native American mental health currently? I'm going to talk to specifically about things that we're doing at Two Feathers in the last 2 years in our community. But I think my mentor, Dr. Joseph Gahn, who's a Gros Ventre and a psychologist at Harvard, captures it best when he says that we're in a post-colonial predicament. On one hand, we have and continue to have urgent needs. For example, in Humboldt County, Native American people die 12 years earlier than any other group of people. That's an issue. That's dehumanizing, right? And on the other hand, we have incongruent clinical services. And so at Two Feathers, we're really trying to wrestle with this predicament through working with specifically young people, specifically in the schools in a large part, and really how do we provide culturally congruent services in creative ways? Change slide. I think in the last 2 years, it's really been an exciting time to be at Two Feathers. We have increased our staff from 4 to 29 now. In 2019, we served over 400 youth from 45 in 2017 and 18. We are developed partnerships, including with the Klamath Trinity Joint Unified School District, where we're providing school-based mental health services. Before we got up there, I think maybe there was 5 to 6 kids being seen in counseling in the school district. And I don't think that's an exaggeration. And right before the pandemic hit, we were seeing close to 60 kids each week in individual therapy, and many more in group therapy and our prevention-based programming. And so, you know, we really have tried to build trust with the community and invest locally. And so next slide. And so if we think about those numbers and some of the recent success that we've had, the question then becomes, well, what are you all doing? And I think hopefully this will offer those of you that are tuning in today some better understanding of what mental health should look like for Native people. And so, you know, a big part of what we've done is community organizing and grassroots organizing. Over the last couple of years, we've required our team to get out of the office. We required our leadership to get out of the office and build those partnerships in very remote rural parts of the area. And then, you know, everything that we've done, we've infused it with culture. Culture as a verb. We borrowed and used our local practices, our ceremonial traditions and practices in all the programming that we're doing. And from that grassroots movement sort of mindset approach, infusing with culture and everything that we do, we've got engagement, and then we got trust. And so the important point here is, before getting to mental health interventions as is, we had to do the grassroots movement. We had to infuse everything with culture, listen to the community, bring in respected elders, and then we can get into the interventions. And the final point here is that I think that we have to think, as some in many Native American communities think, that we have to look in the next 7 generations. That if we're going to think about a mental health system that works for Native people, we have to have intensive services. We have to change intergenerational cycles. We have to think like a good ancestor and think 7 generations forward. That's what we're trying to do at Two Feathers. That's what I think has been working. But like I said, we have much more to do and we need help. Next slide. And so to briefly summarize what I've just said, because we only have 7 minutes, I want to emphasize that if you sit with some of the youth that we work with at Two Feathers, if you get proximate to severe forms of human suffering, you will often see intergenerational cycles of poverty, racism, abuse, and institutions that never showed up for them or showed up and went away. We have to change this. We have to get to the root causes of these struggles. And we're going to do that through community organizing, prioritizing prevention-based programming to help Native communities not just survive, but to thrive, to have self-determination. And lastly, I feel like, you know, I'm an example of having community support and how it takes several generations to heal. You know, my grandfather here, he was the sort of first one to start to change cycles in my own family. He went to the military. He got sober later in his life. He emphasized hard work, thinking about others. And then my father got some of that wisdom. But my father also struggled with alcohol. But he got sober at 12, when I was 12 years old. And then, you know, he's been the chairperson of our tribe for the last 30 years. And I had some of the similar struggles as my grandfather and my father. But I'm now 13 years sober. And I've used the mental health system to help me get sober. But, you know, I had the awareness, I had the resources due to these intergenerational changes in my own family and the positive growth that my father and my grandfather had. And so, but we have to pay that forward. I, as a sober Native American psychologist, have to pay that forward. And so I just want to say, like, during these times, I believe it's important to remember change is possible. Hopefully you can see with the story of Two Feathers, the story of myself, that we are making positive changes, that the wisdom is in the community, like previous presenters talked about, that we're doing this with a Native American staff of 70% of our staff, that we are creating change and improvements. But at the same time, we need support, that at the same time, Two Feathers' voice, and not only the Native American voice, needs to be heard, and more specifically, that we have wisdom. And if that happens, then I think we have a mental health system in California that will better support our Native communities. Thank you. And we will turn it off to John, I believe, who's next.
Thank you so much, Virgil, for those really powerful reminders. And um, I just want to say thank you to everybody on these panels and the speakers, and of course, Wellbeing Trust and Kritika for bringing us together today. What we're talking about is so important, and I've spent much of my career as a pediatrician and public health advocate focusing on the pursuit of justice and equity and self-determination that we're talking about. And one of my goals here, somewhat as an odd person out, not being a mental health professional, but being a pediatrician, is to just share my excitement for the future and where I think we might be headed in California and beyond in terms of addressing intergenerational trauma. So it's a perfect link to what you just shared, Virgil, and thank you for your strength. So we can go to the next slide and begin. I want to first start by acknowledging, as we've heard, that childhood trauma can look like this. It can look like this. It can look like this. And it also can look like this. And for those who might not recognize, that would be mine. And that would be my grandfather, who watched his family be exterminated among 6 million other people, and members of the LGBTQ community, as well as other vulnerable populations in Nazi Germany not too long ago. And the reason I raise this is because I think, if we can move on to the next slide, no matter when or how childhood trauma has occurred, generations ago versus weeks ago, it's occurred in every culture and community. There's no place on earth where there hasn't been war or subjugation. And we have to acknowledge at the same time, it's occurred with disproportionate and racist frequency and intensity more recently. So this should actually be a uniting factor for all of us as human beings. We all have our own unique stories and wisdom, exactly as was just said, and we all have consistent themes. And these experiences, also known as adverse childhood experiences, this trauma, it literally gets under our skin in our youth, damaging the DNA of developing brains and bodies in critical windows, and is passed down, not just in terms of behavior, which most people think, but actually biologically to our children in our DNA, even with the best parenting around. And so one of the things that's so important, as was shared earlier, is that California was actually already making monumental strides in this regard before COVID. And now, as the governor and our state surgeon general, Dr. Burke Harris, have affirmed, addressing ACEs is more important than ever for our communities. We know safer at home doesn't actually mean safer for children and teens. Fear from the virus, isolation, financial insecurity, and the trauma of racism have dramatically increased anxiety, depression, drinking, partner violence, and child abuse in their parents and caregivers. Next slide. And so research tells us, the trauma these children and teens and even young adults are facing today is going to pose significant risk to their health and well-being if we don't act. And one very real and pressing danger that I'll bring to the table as the CEO of D.D. Hirsch Mental Health Services, which is a national leader in suicide prevention. I'll share some of our work. And also as a concerned father and a concerned pediatrician, is suicide. And I want us all to take a minute just to look at how much greater the risk is for suicide due to childhood trauma compared to all other causes of death associated with ACEs. So as we advocate for mental health funding and resources to open safely, we really need to keep these struggling and suffering kids top of mind. This is actually, if you go to the next slide, what the CDC director a few weeks ago noted. We're seeing far greater suicides and deaths from substances than we had in young people pre-COVID. We've actually seen very similar distress worsening over the recent years, as has been said, with the silent mental health crisis in America on our National Suicide Prevention Lifeline and Disaster Distress Lines. D.D. Hirsch is one of only 3 centers across the nation that fields the national distress line for natural and man-made disasters. And what you see now during COVID are significant bumps in distress from mental health, fear, relationship challenges. These are very real. And so we have to think about how we're going to address it. And very much in line with what was shared, I'm here to say, ultimately, we're going to get through this by working together and building our collective strengths. Younger generations' mental health awareness and collaborative norms, and not really concerned as much about stigma, can be combined with older generations' wisdom, and that wisdom of the community and community elders and leaders. I love that. And the guidance that this too shall pass. We really need to leverage everyone in order to revitalize and democratize the mental health workforce, including peers with lived experience, paraprofessionals that you're hearing somewhat about today. One way I want to share that's very future forward to seed intergenerational collaboration in the workforce is actually, has been shared through a comprehensive approach to care based on the entire life course of health and well-being, often called lifespan or life course care. And when people actually get help themselves in a certain way, then they realize, oh, it can be done, as we've heard. Right now, most of our health and human services treat children in one bucket or silo and adults in another bucket or silo. And that makes zero sense if we actually want to prevent childhood trauma, mental illness, suicide, and deaths of despair. The financial reason underlying this, which gets to thinking about future forward policy, is that over time, all human beings, no matter where they're from and what the unique variables are to their story, typically have a consistent sequence of events. This is some data from colleagues at Oregon's Health Share of Oregon, really value-based payer. And they looked at their most costly members and were surprised to find this narrative, that the members had predictable, sequential, and cascading adversities throughout life. So what I'm proposing is that in the near future, we should be able to prevent the next generation's childhood trauma taking that generational lens by looking at these sequences and how different points of care throughout our life can better coordinate. Depression and anxiety, for example. These are likely the first ACEs that any child experiences from his or her parents. For optimal prevention, they need to be identified and managed continually in teens and young adults before they get pregnant, and then during pregnancy and into parenthood. This is what will prevent the cascade I showed you and lead to healthier future generations. Same goes for treating substance use, dating, partner violence in teens and young adults. What's also cool is this is very similar in terms of risk analysis and predictive care when it comes to suicide prevention. And that's where D. Hirsch and others in this field are headed. Much how medicine, physical health, has moved to more precisely prevent cancer and heart disease, things we have heard are less costly in some ways in terms of death nowadays. But in physical medicine, they're focused on precision medicine, each person's unique biology, which includes our intergenerational trauma, as well as current environment, current protective and risk factors, including ongoing trauma, exposure to racism, etc. Suicide prevention also requires someone available at all times on every channel, phone, text, chat, app, in every language. That's going to require major investments in California in technology, marketing, communications, and a diversified workforce that essentially utilizes peers and professionals in teams, as we do at D.D. Hirsch, to successfully provide what are very emotionally draining and life-saving services day in and day out. Ultimately, I believe that our collective vision and innovation, as Tom shared and everyone here has shared, is going to be on full display for the nation and the world as we rise to meet the increased mental health demands of COVID-19. That'll set the stage for universal suicide specialized services and trainings like we offer at D.D. Hirsch to save the most possible lives. For all traumatized children and adults to have life course care that takes an intergenerational and a really scientific sequential approach to prevention. And for people of color and other vulnerable populations we've heard about today, like LGBTQ and foster youth, to have justice in how our systems engage and care for them now and well into the subsequent generations. So with that, I'll pass it on and say thank you for having me, everyone. Really thankful to be here. Maggie Merritt, please take it away.
Thank you so much, John. And thank you to Ben and everyone at Wellbeing Trust for inviting me to join you today. This is a really important conversation, and it's great to be here with you and among so many of California's leaders in the mental health field. The Steinberg Institute is a nonprofit public policy institute that was founded in January 2015 by California's former State Senate President Pro Tem and Sacramento's current mayor, Darrell Steinberg. Our mission is to advance sound public policy and inspire leadership on issues surrounding brain health. We seek to educate decision makers in a way that would lead them to claim mental health as a top-tier priority throughout their careers. We need to bend the curve in our treatment paradigm to move from a system that focuses almost entirely on stage 4 care to one that focuses on stage 1 before brain illness becomes disabling. We're working to build a network of integrated care so that mental health is treated with the same sweep and urgency as physical health. And we must break through the stigma that keeps people from reaching out for help and maintains a system of care that does not meet the needs of people they are here to serve. Due to the strong leadership of our founder and board and the hard work and dedication of my small team, I would say that the Steinberg Institute has had an outsized impact on policy over the course of the last 5.5 years. I want to give you 4 examples of some of our recent work. In 2016, we wrote and sponsored a piece of legislation that created the No Place Like Home Act. This bill authorized the use of existing state mental health funds to pay up to $2 billion in bonds for supportive housing linked to treatment for people with serious mental illness who are homeless or at great risk of becoming homeless. That bill was signed into law by the governor, but then was stymied by legal disputes. So in 2018, the legislature placed the measure on the November ballot. It became Proposition 2 and received more votes in support than any other initiative that year. Counties have been applying for and utilizing No Place Like Home funds to build permanent supportive housing since then. In 2018, we sponsored SB 1113 by Senator Monning, which authorized the state to develop and promote the first ever voluntary standards for workplace mental health, which would provide managers the training they need to properly accommodate people at work who are living with a mental illness, just as we accommodate people with a physical disability. And then we've worked to develop a statewide strategic vision for prevention and early intervention in mental illness, with the aim of standardizing and scaling up best practices across the state. And finally, AB 1315, we created a first of its kind public-private partnership that provides both funding and incentives for counties to focus new resources on early detection of psychosis and prevention of serious mental illness in young people before it becomes disabling. Our advocacy also includes increasing the training law enforcement receive in de-escalation techniques, promoting basic psychiatric training for primary care providers, and securing funding for suicide prevention policies in schools. If you'd like to see our entire legislative package, you can go to our website at steinberginstitute.org. But that brings us to 2020. California is facing a $54 billion budget deficit, the state's worst budget gap since the Great Recession. It's been a real reversal for California. We came into 2020 with a $6 billion surplus and growing reserves. On top of that, COVID-19 made it impossible for the legislature to meet as they typically do. The legislative session has been cut nearly in half, forcing committee chairs to drastically limit the number of bills heard. As a result, they are only hearing COVID-19 related legislation. And we, of course, could argue all bills related to mental health and addiction are COVID-19 related, given the impact it is having on all of us. So now I just want to tell you a little bit about our top priority legislation that's moving this year. First, we have SB 803 that is authored by Senator Bell, and this bill would establish a statewide and county-based peer support specialist certification program. As you probably know, peers draw on life experience and specialized training to deliver valuable support services in mental health and or addiction treatment. Once signed, this bill or this program would be administered by the Department of Healthcare Services and would bring us into alignment with 48 other states who already certify peers. Our top priority legislation this year is SB 855, which is authored by Senator Wiener. And we're working together in partnership with the Kennedy Forum, which was founded by former Congressman Patrick Kennedy. SB 855 seeks to strengthen the California Parity Act to require that insurers cover medically necessary treatment for all mental health and substance use disorder to ensure individuals receive the comprehensive care they need to treat their underlying conditions. Current law only requires insurers to cover 9 severe mental illnesses and does not include conditions like PTSD, generalized anxiety disorder, opioid addiction, alcohol or eating disorders, to name a few. SB 855 would actually define what constitutes medically necessary treatment for all covered conditions, rather than leaving this determination to insurers. It also requires the medical necessity determinations be consistent with generally accepted standards of care and prohibits limiting benefits or coverage to short-term or acute treatment. And it also prohibits plans from denying medically necessary services on the basis that they should be or could be covered by a public entitlement program. Legislators have overwhelmingly supported this bill with a bipartisan 30-5 vote on the Senate floor and a 13-0 vote in the Assembly Health Committee just last night. We have more than 60 organizations in support and a strong coalition that continues to lobby in its favor. The opposition is no surprise, it's the insurers and the California Chamber of Commerce. Our current mental health system is a publicly run stage 4 system. We need a system that is committed to providing mental health care early. Could you imagine your doctor telling you, having just found out you had stage 1 cancer, to come back when you have stage 4? That's exactly what's happening now, and is why we're committed to securing the governor's signature on SB 855. Just briefly, some of the other issues we are tackling this year include data collection on board and care facilities, same-day billing, mental health in schools, the behavioral health workforce shortage, restorative care, establishing community-based emergency crisis response programs, and suicide prevention. I'll leave that here for now and want to thank you for your time. The work all of us are doing matters, and I look forward to working with you as we move forward. Now I'll turn it back to Bill Smith, the founder of Inseparable.
Thanks, Maggie, and thank all of the panelists for these fantastic conversations. I would like to invite our panelists to all unmute and turn their cameras back on. And we're excited to start with some questions, and would encourage people to add questions to the webinar chat, and I will give those to the panelists. But I want to start with a general one, because we asked everyone who's participating in the webinar today in a survey about some of the gaps that they see in California around mental health. And one of the biggest themes that emerged was about the work being siloed. And I would just briefly like each of you to just say a minute or two about your organization's role in comprehensive planning for mental health for California, and how we ought to be thinking about getting out of those silos. I'll kick it to LaShawn first. I'll put you on the spot.
No, that's fine. Thanks, Bill. I think it's a great question. So Children Now, we cover essentially every area of a child's life that you can think of, we have staff that, covers it to some extent. So it allows us the ability to have conversations about mental health in schools, mental health in the early childhood space, mental health in child welfare, et cetera. So we have really been intentional about thinking about what children and youth need across child-serving sectors. The challenge has been the state is not necessarily there yet, right? Like the government. So a lot of our conversations, even though we're having, whole child conversations and much more of a global lens about the child, it's been really difficult to get the state to think that way, primarily because of how funding works and the different rules and regulations depending on the field.
So I can follow that up. And I'll caveat this with saying that I became Didi Hirsch's CEO less than a month ago, so I'm still learning what our role is. But thank you for that. I have spent much of my career trying to address these silos, and in a former life, I led a national initiative, including one that's growing in California with the help of Alex Briscoe and the California Children's Trust, to integrate behavioral health and mental health services into pediatric primary care. And one thing, sorry, I'm getting a ping that my voice is low. So one thing that I'll share that I've learned very recently is that our systems of mental health services, our carve out, is arguably one of the most serious, pervasive, and persistent forms of structural stigma in the United States. We basically allow our payers in California to discriminate against those with mental illness, whether it's on the managed care side, and they're about to be audited, we hope, by the government, that's important, or on the specialty mental health services, where our contracting is Byzantine, is the word I can only use coming from the outside and looking at it. So we have to deal with the financing and get the financing right. And sadly, because of our recession, the state of California will not move forward with what we call CalAIM, which is to get to that single payer approach through pilots and collective work. That's being pushed back. So I view the role of my organization, Didi Hirsch, as one of the largest providers of mental health, substance use, and suicide prevention services in California, that has a reputation, I've learned, thankfully, for quality, for innovation, for really being leaders. We lead the statewide suicide prevention collaborative of all the statewide centers that feel the calls to the National Lifeline. I view it as our job to lead by example, to really focus on where we can improve those metrics. As LaShawn said, we can't necessarily start top down to fix those financial injustices, but we can start from the grassroots and say, here's what quality care looks like. Here's what outcomes ought to be. And I believe Didi Hirsch is going to say, follow the leader with the appropriate resources and say, this is what we can see in terms of mental health outcomes. And one vision that my team and I are really coalescing around is that healthcare really should be whole person care. We're all saying there's no such thing as health without mental health. Well, why shouldn't the specialty mental health systems be health systems like everybody else? There should be no wrong door. People agree on that. So why couldn't we have systems of healthcare, all forms, primary care, specialty care, that are based on mental health service delivery systems? So that's a turning this on its head way of thinking about integrated and whole person care that I'm excited for innovators like Didi Hirsch and others to show California, policymakers, and payers we can do this better, and we can have better physical health outcomes as well as the mental health outcomes and reductions in the deaths of despair that I described.
And unless Virgil or Maggie, unless either of you have something, I'm gonna take us on to the next question. That's super helpful, John and LaShawn. A question from Jen Lee. Where do you see technology and how it can help improving mental health access and treatment for Californians?
I don't want to dominate the airwaves, but I did a stint in tech. So I'll just say Our former mental health czar, who's now in the private tech sector, if only he were here, he'd probably have the best answer. My answer is there's actually a proliferation, thousands of tech ventures on the private side. And one of the things that injustice in our financing on the specialty mental health and other sides of mental health care has led to is that we don't have the technology infrastructure. We don't have the unrestricted capital to actually use our expertise and help those tech companies or even build out our own innovations in tech. A large physical health system does, because they've been feeding off the teat, if you will, of fee-for-service reimbursement for so long with their cardiac catheterizations. I should be able to do that same thing with suicide prevention. So we just don't have that infrastructure. And the real risk of this is actually that there's a tremendous gap in terms of quality. There was a recent meta-analysis that looked at technology companies and startups, and the evidence really isn't there. And I'll applaud our mental health plan in LA County and our Board of Supervisors for investing in one of the most evidence-based apps there is that I actually use, called Headspace. So everyone in LA County now can get a membership to this through our public system. And that type of mindfulness has been shown to reduce stress and trauma like we're all experiencing. But I think we need to focus on how we invest in the technology infrastructure, enabling mental health systems and service delivery to catch up vis-a-vis tech. And of course, as Tom said, how do we bring the private industry to the table so we can really partner and say, we've got the expertise in brick and mortar, you've got the tech, let's get it right.
Yeah, I'd really like to play off of what John was just saying. Dr. Insel is the chair of our board, and I know that if he was here, he would make it very clear that, you know, our youth really are not interested in walking into a brick and mortar mental health clinic at this point, that they're much more prone to seeking support via texting, you know, and other kinds of apps. And I think we really do need to dig in deeper with the private industry and try to identify which technologies are really setting the standard and really are producing good results for our youth in particular. And then for our Central California and all of California, especially during COVID-19, telehealth is just so incredibly important. And I'm glad to see that, you know, we've provided some funding so we could expand telehealth access to everyone across the state right now. And I hope that it continues. But like John said, I think LA County has done just a great job by lifting up Headspace in a way that is accessible to everyone in that county. And I hope more counties follow their lead.
And Maggie, I want to play off that and give everyone a plug again to contact their member of Congress, because making telehealth permanent is one of the things that we're really pushing Congress right now to do. Mm-hmm. I want to combine a comment that we just got, and it speaks maybe to John's work, but that, you know, many people in rural and indigenous social work struggle with access to technology. And maybe, Virgil, if you could expand on a little bit from Dr. Boyd's comment earlier about how we've worked for decades to embed services into schools, and now schools are closed. How do we build community-based safety nets instead?
Yeah, I think
equity wins.
Yeah, I think it's a good question. I think, you know, up here, you know, the schools are, you know, going remote, and the ones that aren't getting online and technology being of use are the ones that were disconnected before the pandemic. And so I think that it speaks to really genuine, deep partnership of, you know, using the community resources and people to be able to get the technology to in the houses. But because if you don't have trust, if you don't have relationships and a genuine partnership, then the technology is of no use. And so I think that it speaks to the importance of that sort of grassroots organizing and really building trusting relationships with, technology based or technologically based private partners and counties and stuff, so that you can reach those that most need the technology. And it's not going to happen if there isn't a genuine partnership and a genuine commitment to building that trust and that safety, because there's a history in this country of breaking promises and not following through on commitments. And so I think that would be what comes up for me.
Yeah.
In a slightly different direction here, one of the questions we got from James, do any of the panelists feel financial counseling and education could improve one's overall mental health? Because we certainly know there is a recession that's devastating millions and millions of families happening at the same time in this pandemic moment.
Well,
So
go ahead,
Maggie.
No, you go ahead, LaShawn.
Okay. Yeah, so, what I'm familiar with is more of the idea and the fact that, poverty is a thing that is stressful and anxiety ridden for families. And, I think the thing about poverty is that you can't really educate it away. Like the numbers just don't work for families. So, I know that where the research is really about lifting the ability to lift families up out of poverty is really going to help where they are emotionally and mentally.
So I want to do two things. One, I want to ask these fantastic panelists if you wouldn't mind putting your link to your website and either a social media handle or an email address in the chat to all panelists and attendees, so that folks can feel free to reach out to you with any additional questions or discussions, because we're nearing the end of our time together. And then for our second part, I wanted to ask each of you in this moment, what is one thing that is giving you hope or a reason for optimism based on the conversations we've been having today and the work that you're doing and the things that you're seeing. So one thing that gives you hope, and I will ask Virgil to kick us off.
Yes, I think during these times, because of the things that are happening nationally with around social justice, around racial and ethnic issues, what's happening with the pandemic, I think at least in the schools and also in other institutions, we're beginning, it seems, to rethink what school looks like, to rethink what mental health looks like, to rethink what the criminal justice system looks like. And I think that's very hopeful for the Native American communities, because these institutions, these systems have not been set up to support my family or the community that I come from. And so to have us have seats at the table, to listen to us, that we have wisdom in the community. And I think that I'm hopeful, because it seems like there's a little bit more listening coming from the governor's office and for the state of California and across the nation, because we do have to rethink and reimagine institutions such as the mental health industry and schools.
Fantastic. Thank you, Virgil. LaShawn, I'll go to you next. What's giving you hope or optimism?
Ditto with everything Virgil said. I mean, I think this is the first time that I've seen state government being so willing to talk openly about race and the implications of race and its impact on health, which is great to this extent. So we're really, really optimistic about that. I think the pandemic has also shined a light on our economic problems within families that a lot of families didn't even realize were problems, right? It wasn't until the pandemic hit that I think a lot of American families realized exactly how unstable they were financially, and really has shifted the needle on the definition of what it means to be economically stable from an individual and from a family standpoint. So really highlighting the need and the conversation around childcare has been, just really exciting for us. Highlighting the need about, economic stability within families has been really exciting for us as well. And unfortunately, I think it took something of this measure to really bring that conversation to the forefront in a way that it's happening right now.
Fantastic. Maggie?
Yeah, so I agree with everything that's been said by Virgil and Sean. Ditto to both of you. And, from my perspective, I also am hopeful because everything that's happening in our world right now has really brought a level of vulnerability to all of us, to all the decision makers, and all of our communities that wasn't necessarily there before. And I think that vulnerability creates access to possibility. And that's, when the governor is feeling the impact of the fact that his kids can't go to school and, all the way across the line, then we can actually begin to have real conversations. When I'm having a Zoom meeting with the chief of staff of the governor and, her partner runs across the back of the screen, half dressed, there's a vulnerability and an access that is created. And there's a recognition that, without each other, we're really fragile, and that we really need to be in this together in a real way. And that gives me great hope. That really, really does.
Thanks, Maggie. John?
I don't know what the equivalent of ditto is for four people, but tritto, quid quadritto, something like that. Everything everyone said. And I'll just say, for the first time in my career, I feel like we have tremendous advocates for vulnerable populations, people of color, LGBTQ, you name it, in high levels of government. That I've never seen that before. People who advocate for women and children. We have a Black female pediatrician, Surgeon General in the state of California. And I think thinking about the halls of power and how change gets made, we I would say, are kind of the grassroots. But even at the grass tops, the governor came in with mental health on his agenda. And yes, the budget deficit probably put a short fuse in that, and we're going to hopefully hold him accountable, even so. And yet, when did we ever have government people who talked about this stuff? We have the Black Maternal Health Caucus in Congress. So people are focused on intergenerational trauma and adversity and communities and families and mental health in ways that have never happened in probably history, let alone in California, where I think we really are leading and have been leading the way forward. And so I'm tremendously hopeful that we have allies. And I'll just say, last night I saw a tweet from our Surgeon General who said, as a mother of 4 Black kids, I really appreciate this. And it was a viral video of a brilliant Black comedian. I don't want to mispronounce his name, but he's literally saying gets pulled over by the police. And for the first time in his life, a white woman was across the street filming. And he said, we have allies. That is the difference. It's when we work together and we acknowledge that we all can contribute in our personal and professional experience and expertise that we're going to take this forward. So we have allies in so many places, and we should be very grateful for that, and we should be leaning on each other with our vulnerabilities to lead California and the union forward.
Thank you so much, John, and thank all of you. I'll just close by saying you are what gives me hope. We have people that are engaged in this work on behalf of, as one person commented in the chat, a lot of people who don't see a lot of hope right now. So we're having conversations about equity and the work ahead, and in new and exciting ways to bring hope to people who don't see it right now. So thank you all so much for being here for this conversation. Thank you to everyone who has stuck with us online. We spend a lot of our time staring at screens these days, but these are important conversations to have. Thank you, Wellbeing Trust, for bringing all of us together. All of this conversation has been recorded. We'll share it with all the participants here, as well as all the fantastic resources that have popped up in the chats. And with that, we will say good afternoon and to all be well.
Thank you. See you later.
Thank you.
Thank you.
Thanks so much. Have a great day.